Good evening, everyone. Thank you for joining our online CME live today from Gleneagles Hospital, Kota, Kinabalu. My name is Lucy, and it is with great pleasure that I welcome everyone to our online CME live event, especially to those who have followed and support us from the beginning. Today, we have Dr. Timothy William, our resident infectious disease specialist and physician, to share with us on the hope and fear of the COVID-19 vaccines. Before we start, allow me to brief you a little of Dr. Timothy's background. Dr. Timothy William is one of the leading experts in infectious disease in Malaysia. His expertise includes malaria, dengue, tuberculosis, STDs, and AIDS. He is one of the committee members for the COVID-19 vaccine working group for the Ministry of Health of Malaysia. Dr. Timothy William is also an author in National Guidelines on Adult Vaccines and Infection Control. He is the president of the Infectious Disease Society of Kota Kinabalu, Sabah. So if you have anything to ask Dr. Timothy, please send it to the comment section, or you can WhatsApp your questions to the phone number as stated below, and Dr. Timothy will try to answer your questions towards the end of our session. Without further ado, I will pass this session now to Dr. Timothy. Good evening, Dr. Timothy.
Thank you very much, Lucy, for the kind introduction. And it's an honor and a pleasure that I am able to be here to be able to share about the hope and fear of the COVID-19 vaccines. I would like to thank all of you all for tuning in to listen. Now, COVID-19 has been the worst pandemic that has ever engulfed or affected us, all of us, during our lifetimes. It has been devastating. It has affected every single life, every life of ours, and it has borne a lot of difficulty to the world. Over 2.7 million new COVID-19 cases have been reported last week, just last week alone, and that's about a 2% increase compared to the previous week. And since the pandemic, there have been 2.6 million people who have already died because of COVID-19. Just to give you a little bit of perspective, as of 2018, about 700,000 Americans have died of AIDS. But in 1 year alone, more than 500,000 US citizens have died of COVID-19. So 2.6 million deaths in 1 year due to this new virus is indeed devastating. If you look at the coronavirus world map, as you can see, last year during this time, most of us were not worried. We were not talking about how bad COVID was going to be. We were debating whether we should travel, whether we should wear masks. In fact, even wearing a mask wasn't debated. And as you can see, the numbers have grown up to roughly about 800,000 new cases per day, and it's slowly beginning to come down. There have been, as of today, 117.6 million reported cases of COVID-19. This is another weekly report of COVID-19 cases weekly by the WHO region and global deaths. Again, it shows the rising numbers of the COVID in all areas, the Americas, Southeast Asia, Europe, Eastern Mediterranean, Africa, and Western Pacific. The numbers have continued to rise, and it seems to be coming down temporarily. In Malaysia alone, this is just from yesterday's figures, we have already had 317,000 cases in 1 year with 5 deaths and a total of 1,191 deaths. Now, the fatality rate seems to be 0.37%. Of course, when we look, this percentage seems small, but the sheer number of cases, number of people who have died is high, 1,191 in 1 year. These 1,191 people have died because of COVID. Now, what are the objectives of the vaccine? The vaccines are to prevent SARS-CoV-2 infection. This is our only hope of curbing the pandemic. And the objectives are to reduce the risk of being infected with COVID-19, reduce the risk of severe COVID-19, including deaths, reduce the risk and spread of COVID-19. And hopefully, with all of this, our pandemic may come to a controllable level. Now, there is some good news. In Israel, confirmed COVID-19 cases since they started vaccinating in the week of December 19, 2020. For Israelis, in all age groups, the number of COVID-19 cases have come down. 89.9% have had at least one dose of the Pfizer-BioNTech vaccine, and it has shown a 43.4% reduction in the new cases and 32% reduction in hospitalizations. This is indeed very encouraging because these are real-world results. And these real-world results are not study results, and the results are very reassuring. Of the 416,000 people that were vaccinated, only 254 had gotten COVID a week after their second dose, and all the cases were mild. There were no cases that were severe and no one died. The efficacy rate was about 91%, and in regards to the variants, about 80% of Israel's infections are the B117 variant. I will talk to you more about the variants later. So, in Israel, it shows in real life that the COVID vaccines cause a reduction in transmission. The viral load of 1,000 COVID-19 tests from December 2020, before the vaccinations began, was compared with 1,000 COVID-19 tests from January 2021, when most over 60s in Israel had been vaccinated, but few people under 60. The viral load was much lower among the COVID-19 tests in January compared to December. This theoretically would translate into a reduced infectivity. This is the COVID scheme, a diagram of the COVID SARS-CoV-2 virus. There's the spike protein, S, membrane protein, the lipid bilayer membranes, envelope protein, nucleoplasmid protein, and then this is the RNA. So the vaccines, the theoretical vaccines that can be used to fight against this COVID virus will be the replicating viral vector vaccine, non-replicating viral vector vaccine, recombinant protein vaccine, virus-like particles vaccine, peptide-based vaccines, DNA-based vaccines, RNA-based vaccines, and plant-based vaccine. Or you can have the whole virion, it is the live attenuated vaccine, or the inactivated vaccine. So generally, these are all the different classes of vaccines that can be developed to fight the COVID-19 virus. First of all, we also have to have a very basic understanding about vaccines. Protection is induced by currently available vaccines against the viruses and is primarily based on virus neutralizing antibodies. So what do these virus neutralizing antibodies do? These antibodies usually block the interaction of the virus with its cellular receptor, or prevent a conformational change required for the fusion of the virus with the cell membrane. So this is the SARS-CoV virus, and you can see the coronaviruses have their names because they are decorated by prominent S proteins. So these are the S proteins, and it's from this that the coronavirus gets its name. It looks like a crown. Now, it is the only viral protein that interacts with the host cell and is the most diverging protein between the different coronaviruses, particularly in its receptor binding domain, the RBD, which is the green color. This green here, the receptor binding domain. Now, what happens is the RBD binds to the angiotensin converting enzyme 2 receptor on the host cell surface. That's the human cells which have this angiotensin converting enzyme receptor. So this receptor binding domain binds into the human host cell surface, and the ACE2 receptors are found in many parts in the body, namely the upper respiratory tract, the lungs, and all the other organs, including the kidneys, the brains, the brain, the heart, endothelium. So any part of the body that contains ACE2 receptors, the SARS-CoV-2 virus can actually bind to. The fusion peptide fuses with the host cell membrane. Specific antibodies against RBD and the FP, the fusion protein, can neutralize the SARS-CoV-2 NTD, CTD, and NC terminal domains. So this is the SARS-CoV-2. This is the spike proteins, or they call it the S proteins. What happens? This is the one that binds into the ACE2 receptors in the human cells. Now, T and B cell responses to COVID-19 vaccines. The questions that we ask, that's often asked, is how long will the vaccine be effective? Will it be effective for 1 month, 2 months, 6 months, 1 year, 2 years? What type of immune response will it produce, and the longevity of that response? There are 3 possible immune responses generated by a successful vaccine: the production of B cells or T cells, or both. So this is what happens when a vaccine is given. A viral antigen then is presented to the antigen presenting cell and is activated, and this then activates 2 types of cells, the T cells or the B cells. Now, once the B cell is activated, the B cell then can differentiate into 2, a plasma cell and a memory B cell. The plasma cell then produces the antibodies or neutralizing antibodies, whereas the T cells comprising of the CD4 or CD8 cells then eliminate the infected cell and thus clears the viral infection. I'll go more into this later. So this APC recruit then causes toxic T cell to recognize the infected cell, leading to cell death. So this cytotoxic T cell, it doesn't attack the viral antigen, but what it does is it recognizes the infected cell. It recognizes the infected cell and causes the infected cell to die. Whereas the B cell, the neutralizing antibodies, what the antibodies do is it goes into the, remember I told you the RBD, receptor binding site, and that causes and prevents the virus from binding to the ACE2 receptors. So here the infected cell is killed, and here the cells are not killed by the affected virus because the cells cannot bind to the ACE2 receptors. This is very important later on. So the B cells produce the antibodies, whereas the T cells attack the infected cells. They don't produce antibodies. So antibodies produced by B cells attack the virus directly, and the antibodies produced by the B cell response to COVID-19 are relatively short-lived. It is possible that individuals who have been infected with or vaccinated against COVID-19 could develop a rapid antibody response to any subsequent exposure based on B cell memory. So there are 2. One is I'll just go back here again. You have the plasma cells that produce the antibodies immediately, and you also have the memory B cells which may potentially produce the antibodies later when needed. Recent data indicate that another form of immune response has the ability to provide longer-term protection against COVID-19. The second line of defense is provided by the T cells. Unlike B cells, T cells do not attack the virus directly. The T cells do not attack the virus directly, but instead they target the infected cell, as I showed in the diagram. And this stops the virus from reproducing. You see, the virus can only reproduce in the human cell. It cannot reproduce by itself. So by killing off the infected cells, it stops the virus from reproducing. Now, one of the problems is proving that this is that the T cells are harder to measure than antibodies. So we can't measure the T cells, and thus has not been extensively studied in COVID-19 patients, although there are many studies that are being done now. Both memory T and B cell responses specific to SARS-CoV-2 have now been found up to 6 months after the infection. So after infection, this has been found after an infection, and it's expected that similar T and B cells responses might be expected following the vaccination. Now, I want to go to another concept called selective pressure. Selective pressure occurs when mutant viruses that can overcome the immune system or the vaccines survive and spread. So variants of COVID-19 are appearing around the world. The concern is when we have different variants, the variants may be more transmissible, it may be more virulent, and it may cause reinfection in people who were infected before, and it may cause the vaccine to be less effective or not effective at all. This is the concern that we have with the variants. Now, it is inevitable that the viruses will mutate. All viruses mutate, so it's not really surprising that there are variants. So these are the main variants, although it is not extensive. These are the main variants that are being discussed and the concerns. The United Kingdom, we have the B117 lineage, the South Africa B1351 lineage, the Brazil, the P1 lineage. And these are all caused by the mutations in the S gene. It may be more transmissible and it's spreading globally. It's possibly more virulent. Studies are being done to see whether it's virulent or not. And it may cause the vaccine to be less effective. So this is one example. Brazil, hit by COVID-19 variant, now surpasses the US in daily cases and deaths. The P1 strain from Amazon fills up the ICUs across South America's most populous country, and some patients were left to die. So in Brazil, they had an outbreak earlier, especially in the region of Manaus, where it was thought that most people were infected. But now, the infection has resurged in Manaus and in Brazil. So the P1 strain is 1.4 to 2.2 times more contagious than versions of the virus previously found in Brazil, and 25 to 61% more capable of reinfecting people. So at least in this case, the P1 variant shows that it can actually reinfect people who were infected before. It was first emerged in Manaus in early November. As you can see, early November, the numbers in Brazil seem to come down, but after that, the numbers seem to rise dramatically again until today. By January, the new strain was already responsible for 85% of the COVID-19 infections in the city. Now, this is very, very sobering in the sense that it was thought once people were infected, the chances of them getting infected were less likely, or herd immunity would set in, but not so in Brazil. The first case of COVID-19 in Brazil was reported 377 days ago on the 26th of February 2020. Since then, the country has reported 11 million cases and 268,000 deaths. Now, the good news is, do the vaccines work for the different types of variants? Now, there was some study done showing that the Pfizer-BioNTech vaccine neutralized the Brazil P1 variant. At least in the lab, it seems to be effective. And the UK B117 and the SA135 lineages. So at least in this vaccine, it shows that there is some neutralizing antibodies that can go against these three variants, the Brazil P1, the B117 and the SA variant. Now, many of you all may ask, what is the vaccine testing process? First of all, we have the preclinical testing. Scientists test a new vaccine on cells and then give it to animals such as mice and monkeys to see whether they produce an immune response. And then you have the phase 1 safety trials. Now, in this, the scientists give the vaccine to a small number of people to test safety and dosage and to confirm that it stimulates the immune system. And then you go into the phase 2 expanded trials. The scientists give the vaccine to hundreds of people, split them into groups such as children and elderly, and to see if the vaccine acts differently in them. So these trials further test the vaccine safety. And then you go to the phase 3 trial, and you always hear these terms, phase 2 trial, phase 3 trial. Now, phase 3 trials are also efficacy trials. The scientists give the vaccine to thousands of people and wait to see how many become infected, and compare them with volunteers who receive the placebo. So you have two groups. One group, a group that receives the vaccine, and then the other group, who does not receive the vaccine, the placebo. And then what happens is, after a certain number of people have been infected with COVID-19, they compare the two groups, the vaccine group and the placebo group, and to see the efficacy of the vaccine. So this is what is known as the efficacy rate. Phase 3 trials are also large enough to reveal evidence of relatively rare side effects. So it's very important that we have phase 3 efficacy trials. And then after that, there's the approval process. early or limited approval. Now, many countries, they have their own approval mechanisms. So many countries are given emergency authorization based on preliminary evidence that they are safe and effective. Now, because this is an emergency and because we need the vaccines as fast as possible, emergency approval authorization has been given, which otherwise wouldn't have given for other types of diseases. So China, Russia, and other countries have also began administering vaccines before detailed phase 3 trial data has been made public. Now, that is also an issue. Many of the vaccines already have phase 3 trial data, but they have not been made public and they have not been published. So there have been concerns about the risk of jumping ahead of these results. Each country has its own approval mechanisms. So regulators review and complete the trial results and plans for vaccines manufacturing and decide whether to give it full approval. So this happens in our country as well. Now, how did the vaccines how were they able to develop the vaccines very fast this time? One of the reasons is there are many cases of COVID-19. You have to have the number of people getting the disease has to be a large number in order to conduct a trial. So for instance, in a country like New Zealand or Australia, where you don't have many cases, it's impossible to conduct a trial. You can only conduct a trial in a country with many cases. And number two is, one of the ways that they accelerated the vaccine development is, instead of going from phase 1 to phase 2 to phase 3, they actually combine the phases. So some vaccines are now in phase 1 to phase 2, and at the same time phase 3 trials are being done. So on the other hand, there are also vaccines trials have been paused or abandoned if investigators observe worrying symptoms in the volunteers. So they can pause the trial, and the trial can either be resumed or abandoned. So I'm going to discuss about the published phase 3 clinical trial. So I would divide the vaccines. There are many vaccines, but there are some vaccines that have been whose results have been published, and some vaccines that have not been published yet. So this vaccine, the Pfizer-BioNTech, the efficacy of the Pfizer-BioNTech vaccine after the first dose, as you can see, this is the placebo, and this is the vaccine group, and followed up these patients right up to about 112 days after the first dose, and they found that after the first dose, the efficacy to be 82% after the first dose, and 7 days after the second dose, efficacy to be 94.8 as compared to the placebo here. So what they did was, when you give two groups the vaccine, so 18,000 of them had this the Pfizer-BioNTech vaccine, and about 18,000 also had the placebo. And what they did was, among these two groups, they looked at the number of cases COVID-19 out of both these groups, the number of people who developed COVID-19, who got the COVID-19 infection. So among these patients, 162 got COVID-19 from the placebo group, as compared to only 8 in the the vaccine group. And from there, they calculated that the vaccine efficacy was 95%. Now, COVID-19 occurrence at least 7 days after the second dose in participants with and those without evidence of infection. In the vaccine group, 9, and in the placebo group, 169. So when you compare these two groups, you can see that the risk of developing a COVID-19 infection is much more lower in the vaccine group, and they calculated the vaccine efficacy to be 94 to 95%. So this shows in the different age groups, but roughly all the age groups had almost about 95 and above % of efficacy. Now, what about those people who got the vaccine but still developed COVID-19? So in the COVID-19 group and the placebo group, only one after the first dose of the COVID-19 vaccine developed severe COVID, whereas in the placebo, 9 developed severe COVID. and in more than 7 days after the dose 2, only 1 in the vaccine group and 4 in the placebo group. So the COVID-19 wasn't 100% effective. However, it did show that those who develop COVID-19, only 2 cases developed severe COVID-19. And here we also have the Moderna vaccine, which also shows an efficacy about 95% and above, as compared to the placebo. And we also have the Russian, the Gamaleya Sputnik vaccine, where they followed up the patient for 80 days. The green line is the vaccine group, and the blue line is the vaccine group, and the red line is the placebo group. As you can see, the number of percentage of people who develop COVID-19 is much lower in the vaccine group as compared to the placebo group. So from 21 days after the first dose of the vaccine, on day 2 of dose number 2, 16 of the 14,964 participants in the vaccine group got COVID-19, and 6 versus 62 in the placebo group. The vaccine efficacy was 91.6, and this was published in the Lancet Infectious Disease Journal. So this is a summary of the vaccines where you have actual published data. The Pfizer, which is an mRNA vaccine, 95% in a clinical trial. In the real world in Israel, 91%, and 85% 15 to 28 days after dose number 2. And efficacy among the old variants about 92.9, and the B117 UK, no impact on efficacy. Whereas in the B1351 and the B1, the Brazil, the different variants, there was a decrease in the neutralizing antibodies, but not in efficacy. And as I mentioned, Moderna is 94.1, and we have the J&J one dose adenovirus vaccine, 66.1 global vaccine percent, and the AstraZeneca 62% in the clinical trials. So I'll just summarize on all the vaccines that are available. So these are clinical phase 3 trial results that have been published. So Moderna has a 94.1% efficacy, involves 2 doses 28 days apart. The storage is negative 20 degrees, whereas the Pfizer-BioNTech, 95% efficacy, storage is negative 70. It's also 2 doses with 21 days apart. And you have the Oxford AstraZeneca with an efficacy of about 82%. So these results have been published. Now, in Malaysia, we have the Sinovac vaccine. Efficacy is about 50% in the study done in Brazil. I think in Turkey is about 80%. And it's also 2 doses, 3 weeks apart. And you also have the Sinopharm vaccine, which has a 79%. And then the Bharat Biotech vaccine, which some results have come out with 70%. Now, these clinical trial phase 3 results have not been published yet. So most of our data is based on the data which has been given. Playa Sputnik 5 vaccine, 91%. The J&J vaccine. So between December 14, 2020 and January 13, 2021, 13,794,904 vaccine doses were administered. And out of this, adverse events were reported in 6,994. 90.8% were not serious and 9.2% were serious. Anaphylaxis occurred in 4.5 cases per million doses administered. The side effects include pain at the site of injection, painful or swollen lymph nodes in the arm, tiredness, headache, muscle or joint aches, nausea and vomiting, fever or chills. Severe side effects, anaphylaxis, 5 in 1 million for this vaccine, which is actually slightly higher than the other vaccines. The usual vaccines usually cause 1 in 1 million, but this anaphylaxis can be caused in 5 in 1 million. That's actually so far none have been reported as caused by the vaccine. There has been a recent report of 23 deaths among elderly vaccine recipients in Norway, and this has raised understandably safety concerns about the new COVID-19 vaccines. Investigation is still underway. However, up to now, they still haven't found a direct cause of deaths. That means they haven't really found that the vaccine was the direct cause of deaths, of the deaths of these elderly recipients. Now, these are some of the myths and facts of the COVID-19 vaccine. Issue of messenger RNA, mRNA vaccines. Now, the mRNA vaccine does not enter the cell nucleus. The mRNA vaccine is not converted to DNA, and even if the mRNA is converted to DNA, it doesn't. It is not. It is not. It can only be integrated into the DNA if there's an integrase enzyme. So bottom line is the mRNA stays outside the cell nucleus. There's no evidence that the mRNA vaccine can cause cancer. Now, some people have asked, the COVID-19 vaccine really isn't a vaccine, it's actually a medical device. That's not true. A vaccine is a product that simulates a person's immune system to produce immunity to a specific disease and protects the person from that disease, and that's what the COVID-19 vaccines are. Another question is, COVID-19 vaccines use pegylated lipid nanoparticles, especially the mRNA vaccines, and PEG is known to cause anaphylaxis. Well, this is the first time PEG has been used in a vaccine. That is true. Anaphylaxis can occur in people who already have anti-PEG antibodies or a history of severe anaphylaxis. And if you look at the data, there have been 50 anaphylaxis cases reported for Pfizer out of the 9.9 million doses, and 21 reported for the Moderna out of 7.5 million doses. So this is an anaphylaxis rate of 5 in 1 million people, which is actually very, very low. Okay, it's very, very low. COVID-19 vaccines can cause autoimmune disease. The cause of autoimmune diseases is still difficult to identify. All autoimmune diseases are difficult to identify. It's multifactorial. There has been no evidence that the vaccines can cause autoimmune diseases so far. Can COVID-19 vaccine make me sick with COVID-19? No. However, we may still get COVID-19 while waiting for the vaccine to have its full effect. As you can see, the efficacy is only about 95% and some about 70%, which means to say that some people can still get COVID-19 even though they get the vaccine, though in most cases the infection is likely to be less severe. After getting a COVID-19 vaccine, can a COVID-19 test be positive? No, the COVID-19 antigen and PCR test will not be positive. Some serology tests may be positive. If I already have had COVID-19 and recovered, do I still need to get vaccinated with a COVID-19 vaccine? Yes, because there's still a small chance you may be reinfected. Are the COVID-19 vaccines safe to be given in pregnancy? Now, there are limited data. There is limited data about the safety of COVID-19 vaccines for people who are pregnant. The risk, however, of severe COVID-19 is higher in pregnant women compared to non-pregnant women. So there are two issues. One, agreed, there is limited data on the safety of COVID-19 vaccines. All the studies have done, they did not include pregnant women. However, there's no evidence of adverse effects and they're still monitoring. So the risk and benefit of the vaccine needs to be discussed with women who are pregnant or who are about to get pregnant so that they can make an informed decision. Now we come to antibody-dependent enhancement. This is a big issue. So do the mRNA vaccines or other vaccines cause antibody-dependent enhancement, ADE, in COVID-19 disease? So what is ADE? What is this ADE that people are very worried about? ADE is when a disease is made worse or more severe in a person who was already exposed to the virus through a previous infection or vaccination compared to people who were never exposed or vaccinated. So you get a vaccine, you hope to get better, but instead of getting better, when you get the infection, you get worse compared to people who were not vaccinated before. Why the concern? Now, AD has resulted from vaccination from respiratory syncytial virus, RSV. Now, this vaccine was never released. The vaccine was stopped at the clinical trial stage and was never released. So there was never ever a vaccine for RSV. It was stopped at the clinical trial stage. Measles, an early version of measles vaccine was withdrawn. The latest vaccine does not cause ADE. And then we have the dengue virus vaccine among children in the Philippines. And we must understand the dengue, there are 4 serotypes, and even before the vaccine came out, the ADE happened in patients who developed secondary dengue. So ADE was already a concern for dengue even before the vaccine came out, and there were some signs of ADE occurring in the dengue virus vaccine among children in the Philippines. Now, the question is ADE an issue in the COVID-19 vaccine? There has so far been no evidence of this in all the trials that have been done. In fact, as I showed you just now, among the people who got the COVID-19, the Pfizer-BioNTech vaccine, those who got COVID-19, who got the BioNTech vaccine, they did not get severe disease. In fact, they only had mild disease. So in the trials of those who had the vaccine and who had COVID-19, they only had mild disease. So if ADE occurred in the vaccines, those who were given the vaccine, they would have developed more cases of severe disease. ADE has not been identified as a result of previous corona infections, unlike dengue. In human studies, people previously infected with coronavirus were infected with different types of coronavirus, and yet they did not experience enhanced disease. In animal studies, experimental animals were vaccinated with SARS-CoV-2. They did not develop enhanced disease when challenged or infected with the virus. And people with COVID-19 who received plasma containing SARS-CoV-2 antibodies did not experience an enhanced disease. So the bottom line in regards to antibody-dependent enhancement, there are no signs of ADE in preclinical animal studies and no signs of ADE in human clinical trials. Now, vaccines are hoped to induce herd immunity. I just want to explain to you what herd immunity is, or otherwise known as population immunity. It is indirect protection. The population is immune either through vaccination or immunity developed through previous infection. Now, WHO supports herd immunity through vaccination. Now, you must understand, allowing the disease to spread to achieve herd immunity is not effective, and it cannot occur. It will likely not occur, and will cause too much morbidity and death. So it is hoped that vaccination will help the human population in countries achieve herd immunity. So this herd immunity, so no herd immunity, so these are the people who are infected and these are the people who are susceptible. The infection can spread from one person to another. But when you develop herd immunity, this green are people who are immune. It's more difficult for an infected person to infect another person because they are surrounded by people who already are immune to the disease. So this can be achieved either by vaccination or by infection. As we keep infection alone is not a strategy for herd immunity. So in herd immunity among those who are vaccinated, so these are the blue, those who are vaccine or immunized, so they cannot get infection, or rather they are unable to spread the virus, and these are the unprotected people. And for those, if they are surrounded by people who are already vaccinated or immunized, the chance of spreading the disease from people who are COVID-19 to the uninfected people is very much less. So the proportion of population that must be vaccinated against COVID-19 to begin inducing herd immunity is not known. The estimates have ranged from 70 to 90%, and this depends on the prevalence of the disease in the country and also to the variants that may come out. For example, measles requires about 95% of the population to be vaccinated. Polio, the threshold is about 80%. Now that the vaccines are out, and I've already shared with you the efficacy of the vaccine, what are the risks? And this, I would like to thank Dr. Kathleen Jatlina. I asked her for permission to share these pictorials. The risks of finding yourselves in different situations. So one person is unvaccinated and the other person is vaccinated. The probability of these two transmitting to each other is very, very high. And of course, the probability of getting diseases, both asymptomatic and severe, is high. So what if they wear a mask? This person is masked and this person is not masked. The probability of the masked person transmitting the virus to the non-masked person is lower, but the probability of the who is not wearing a mask to transmit the person to wearing a mask is higher. So mask actually prevents you from spreading the virus. Now, if both people are unvaccinated but they are masked, the probability of them transmitting the virus to each other is lower. But let's say one person is unvaccinated and the other person is vaccinated, the probability of the vaccinated person transmitting the virus to the unvaccinated person is low, but the probability of the unvaccinated person transmitting the virus to the vaccinated person is high. However, the risk of this vaccinated person getting the disease is much lower compared to if he's not vaccinated, and the risk of the vaccinated person getting severe disease is also much lower. So here we have an unvaccinated child and a vaccinated adult. So the risk probability of transmitting from the child to the adult is lower, and from the vaccinated adult to the child is also lower. Let's say both people are vaccinated, the probability of transmitting is lower on both sides. So that's very good about vaccination. However, we still advocate people to wear a mask so that the probability of transmitting the virus from one to another is even lower to each other, and this is in view of all the new variants that are coming out. So we are all in this together, and we will get through this together. So it's very, very important that all of us work together to beat this pandemic. And with the COVID-19 vaccine, we can see a flicker of hope and a light at the end of the tunnel for us to be able to overcome this pandemic. With that, I'd like to thank you very much for your kind attention.
All right. Thank you so much, Dr. Timothy, for the interesting updates. And we have received quite a number of questions from our viewers today. So let's go to the first one. The first comment, this one is from Dr. Ko Leong Hin. He said, Sinovac vaccine is to be rolled out soon. Why is it some people want this vaccine but ignore the fact that it had no long-term safety data? The same group of people rejected Pfizer vaccine because they say it got no long-term safety data. So what is your comment on this, Dr. Tim?
Well, I think the question many people are asking, I'll try and reframe the question. I think the question many people are asking is which vaccine is better, whether the Pfizer-BioNTech vaccine is better or the Sinovac vaccine better, and which vaccine we should choose from. Now, the only way for us to be able to know which vaccine or which drug is better than the other is to do a side-by-side randomized control trial comparing both the vaccines. That's the only way for us to really know which so-called vaccine is better. Now, in terms of long-term side effects and long-term efficacy, we really don't know because the vaccine really has just come out. So in terms of long-term efficacy, it's very, very difficult for us to give an exact value or the number of months that the vaccine will be effective. However, remember, many people have asked this. Now, the antibodies may not last long in the body after vaccination. What happens when the antibody is not detected? So the question asked is, should I do an antibody test to see whether the vaccine is effective or not? Now, even if the antibodies come down, remember I told you about the memory B cells and the memory T cells. So these memory cells are capable of causing an immune response that can overcome the infection later on, despite not having detectable IgM or IgG levels in the body.
Okay. So the next one, Doctor, this one is also from Dr. Kaur. The government has no plan to do post-vaccination antibody tests. Why is it not useful to know how many seroconverted, Dr. Tim?
Yes, so as I mentioned, we don't need to find out people who are seroconverted, and it's not really necessary, as in the studies that I've shown in Israel. Again, the presence or absence of the IgG and IgM does not mean that the person is not immune to the virus or the vaccine is not effective. Okay.
Okay. So next one, doctor. It is said that all approved vaccine gave 100% protection against COVID death. Does that imply there is 100% seroconversion?
Okay, there's no drug or vaccine that can guarantee you 100% prevention of COVID deaths. All we can see is that so far, among those who were vaccinated in the trial group, no one has got COVID-19 and died from it, or rather has been published yet. Most patients most people who are vaccinated with COVID-19 vaccine only had mild COVID. A few of them had severe COVID. But I would not go so far to say that a vaccine will provide 100% assurance of prevention of COVID-19. That's because for the simple reason that the COVID-19 virus may mutate. So that's why it's still very important for us to view vaccine as just one of the measures of preventing or reducing the risk of infection and reducing a severe disease. We still have to maintain all the other SOPs such as social distancing and wearing of masks and avoiding large gatherings even with the vaccine.
All right. Okay, next one. This one is from Dr. Julian. After COVID vaccination, how many have died from the vaccine and how many have died from COVID-19 despite vaccination, doctor?
So far, there have not been any reported cases of people dying because of the COVID vaccine. There have been people who have died after they've got the COVID-19 vaccine, and investigations are still being held to see whether there's a direct causal link between the vaccine and the deaths. I think that, what's the next question? I think I answered the next question.
The next question is if the efficacy of a vaccine is 95%, does that mean 5% can still get COVID despite vaccination?
Yes, the results 95% still means that there's a 5% chance that a person who gets vaccinated can still get COVID-19. As I showed the data earlier, the chance of them getting severe disease is also reduced with the vaccine, although they get the infection.
All right. And any mention about the severity or long-term sequelae of that 5% compared to if they have not received vaccination at all, doctor?
I think what the doctor means is the long-term sequelae of a person who gets COVID-19 who has been vaccinated compared to the long-term sequelae of a person who gets COVID-19 who has not been vaccinated. I don't think there are comparative studies have been done yet on that.
Okay. Next one, doctor. How long can COVID vaccine protect you from the same COVID virus versus own antibodies after being infected? How about with other strains also?
Yeah. So that question is still not answerable. How long will the COVID vaccines be effective? So all we can say is effective from the day they were vaccinated to now. And as you very well know that these vaccines are still new, so we'll just have to wait to see how long that they are effective. Theoretically, the vaccine should last for a substantial length of time. However, with new variants, there is a strong possibility that the vaccines may later need to be modified and booster doses may need to be given. But that still remains to be seen.
All right. Okay, next one. This one is from Dr. Sharif Iswan. Is there any problems to our patients who diagnosed with RVD infection to receive vaccination? What about viral load suppressed but the CD4 is low?
So patients who are very immune suppressed, they should get the vaccine. The question is how effective the vaccine will be if they are unable to mount an immune response. That question is still remain to be answered. However, the question is whether they should get the vaccine. Yes, definitely they should get the vaccine. Whether they are at a higher risk of developing adverse effects because they are HIV positive, answer is no. Most likely not. There hasn't been any evidence. I think patients who are immune suppressed should receive the vaccine, regardless of whether they're HIV or immunosuppressed because of other reasons.
All right. Next one, doctor. This one is from Miss Jenny. Must the second dose of biotech vaccine be taken exactly 21 days after first dose?
I think if there is some form of delay in taking the vaccine, for instance, if you take it at 4 weeks or 5 weeks or 6 weeks, the evidence shows that even after the first dose, the effectiveness is quite good, as seen in Israel. So, should we get the second dose? Yes. Should we get it definitely at day 21 and not later? I think we can be flexible about that. They may be able to take it 1 or 2 weeks later, but it's preferable to take it at 3 weeks, because that's what the study has been.
All right. Next one, doctor. This one is from Dr. Jason Ong. What is the difference between mRNA vaccine and adenovirus vaccine?
Actually, they are actually both the same. The adenovirus vaccine. Adenovirus just means that the mRNA is the adenovirus. I think it refers to it's just a carrier of the vaccine. I think the adenovirus contains the DNA of the COVID-19 vaccine. It's just a carrier. So these are both. One is a mRNA vaccine, and the other one is in a sense a DNA vaccine. So.
All right. Next one is from Miss Tay. She wants to ask you about the efficacy of the Russian vaccines, because she said she understands that Malaysia has purchased the vaccine. So we know the efficacy of the Pfizer vaccine. So what about for the Russian vaccine, doctor?
I think I've showed you the efficacy of the Russian vaccine. It's already approaching about, let's see. At least from the data, it shows the efficacy to be about 91% of efficacy. That's been recently published.
Okay, noted.
Yeah.
So next one, doctor, this is from Dr. Richard Barrow. For vaccine requiring more than one dose, must the second dose be the same? Would the second injection using a different type still be effective?
I think the question is whether the vaccine has to be the same vaccine. Can we use a Pfizer BioNTech vaccine and then later a different vaccine such as Sino? I wouldn't advise it. I think both the doses should be the same. Both the vaccines should be the same. I don't think we should mix the vaccines, because there's no. There probably may be evidence later that you can, but so far there isn't any.
All right. Next one is from Dr. Shari. History reveals that there were only 12 mRNA vaccines throughout time presented to the FDA, and all were rejected. Any idea on what basis were they rejected, doctor?
I have no idea. Yeah.
Okay, we move to the next one. This one is from Sarom Naus. COVID-19 vaccine, is it safe to hepatitis B or C patients, sir?
Yes, it's safe. Yeah, it should be used.
All right. And also, he asked to give a short comment on Sweden approach of herd immunity. Is it too early to compare or comment on its success or failure?
I think by now we've already shown, as I presented to you earlier, that herd immunity cannot be achieved through infections. That means we hope that people will be immune because of infections. First of all, about 70 to 80% of people need to be infected. That's just being very conservative. And the immunity of the people who have been infected is still unknown. But the more important reason is in order to achieve try to achieve herd immunity through infections alone and not through preventive measures such as wearing masks, social distancing and vaccine, the cost is too high in terms of morbidity and mortality. That means too many people will get sick and too many people will die. So in my opinion, I think it's the opinion of many that the trying to achieve herd immunity by not doing anything and letting the virus just spread is not really, it's definitely not advisable.
All right.
It should not be done. It should not be done. If there's any lesson about COVID-19, if you look at the Manaus in Brazil, where many got infected, a huge population got infected, the vaccine, the infection is still raging in that areas, in these areas where previously they had the infection.
Okay. Next one, Doctor. This is from Dr. Trevor Lim. What is your comment on latest CDC guidelines for those who have been vaccinated and doesn't need to put on mask? What is your comment, Doctor?
What do you mean, the CDC guidelines?
The CDC guideline for those who have been vaccinated and saying no need to put on mask. Is it, Doctor?
Well, I'm not. I think it may mean do not put mask in certain situations, right? So a person who's been vaccinated may not necessarily need to wear a mask if he's in the midst of other people who are already been vaccinated. However, a person who's been vaccinated and if he's near a person who is at high risk of dying of COVID, such as an elderly person who's not been masked, then they should wear a mask.
All right. Okay, next one, Doctor. This is from Dr. Vignesh from Minar Tuaran. Considering the long-term effects are not published yet, will Dr. Timothy, as an infectious disease consultant, recommend being vaccinated? What can be expected as the long-term side effects? Any comparison to previous vaccine to anticipate?
Oh, I mean, I hope with this lecture, everyone will be convinced that they need to be vaccinated against COVID-19. So if you're not vaccinated, please get yourself vaccinated, especially so if you're a frontline healthcare worker and if you belong to those in the high-risk group of dying. There's a real chance of you having severe disease and dying, or even spreading the virus to someone close to you who may actually get the virus. On a personal level, my views on COVID-19 changed a lot when I started seeing COVID-19 patients and treating severely ill COVID-19 patients and seeing COVID-19 patients dying. So this is not a disease that I think I wouldn't say anyone is taking, I wouldn't say that people are taking it lightly, but this is one of the most or the worst diseases that has ever inflicted us in our lifetimes. And of course, you may think that the chance of you dying a person dying is very low. But if you look at the sheer number of people who are dying and the sheer number of people who are being infected, we have to stop this pandemic. We have to be able to control it. So please get your vaccines.
All right. Next one is from Dr. Terry Huang. There is a concern that the adenovirus vector vaccine may cause the DNA of the virus be incorporated into the host DNA nucleus. What is your opinion on this, Doctor?
So actually, so it's coming back to the earlier question. The adenovirus is just a transport that brings the vaccine particle into the cell. So the adenovirus contains DNA and as compared to the mRNA vaccine. Again, so far, I think the question is whether the DNA vaccine can be integrated into the DNA of the host and then cause things like autoimmune diseases or cancer or other diseases. So far there's been no evidence of this happening. I think a lot of the questions are theoretical. What may happen in 6 months? What may happen in 1 year? Is there a biological plausibility of a person developing these long-term side effects? And so far there isn't.
Next one is from Tan. Doctor, would you advise a 99-year-old to take a COVID-19 vaccine? She only has arthritis of the knees and acid reflux, no allergies, and otherwise healthy.
Yeah, I will advise a 99-year-old person to take a vaccine. And I suppose the caution in giving people the vaccines are those who are very, very frail, elderly and very, very frail. Now, in these people, you may be a bit more cautious in giving the vaccine. But certainly, if a person is healthy, we shouldn't use age as a reason for not giving the patient the vaccine.
All right. And also, Dr. Tim, there are few people asking about if the COVID-19 vaccine is safe for pregnant ladies of breastfeeding. What is your comment, Doctor?
Yes. So, there are two issues to consider. One is COVID-19 affects pregnant ladies worse than it does women who are non-pregnant. So they have a higher risk of getting severe COVID disease, and that will also impact on the pregnancy. And not to mention the long-term effects of the COVID infection. And on the other hand, you have the vaccine. Now there have been, because of the disease has not been long, and the vaccine trials did not include pregnant women. There's very limited data on the safety of COVID-19 vaccines on pregnant women. So, however, that said, among the animal studies and also the women who have already been vaccinated who got pregnant and women who were pregnant, they did not see any severe side effects. So, doctors, we need to, in this group of patients, we need to discuss with the pregnant mother on the risk and the benefit, and then for them to come to decide whether they will take the vaccine or not. Now, if you were to ask me, should they get the vaccine? Yes, I would advise pregnant women to get the vaccine, but they too, it'll be a joint decision between the physician and the pregnant women.
All right. And
but all in all, I would advise pregnant women to take the vaccine.
All right.
Yeah.
Okay. So next one, this one is from Dr. Terry. I think you already answered, I think the same question where she asked any concern of giving the COVID vaccine to elderly people who are more than 85 years old, Doctor.
Sorry, I forgot to mention just now regarding breastfeeding mothers, definitely no contraindication at all. They should be given the vaccine. And yes, elderly people should be given the vaccine as well.
All right. Okay.
Because the risk of dying is very, very high in severe disease.
All right. Next one is from Dr. Jason Ong. If a person took a vaccine before, for example, flu, pneumococcal, is there any duration to avoid before taking COVID vaccine?
No, there isn't.
And is it safe to take along with other vaccine, Doctor?
You mean together, the COVID-19 vaccine together with other vaccines? Well, actually, on a practical issue, I would advise against it. Of taking vaccines together, but there's no real recommendation on that. But I would personally advise not taking it together.
All right. Another one from this one is from Saiful. If between first and second dose of vaccine, someone get COVID-19, can the patient proceed with the second dose?
Well, I think they can, but after they recover from the COVID-19 infection,
all right.
So they can take the second dose.
All right.
But that's an interesting question.
Yeah.
They think of it.
Yes. All right. Next one is another one from Dr. Vignes. What are the current guidelines in Malaysia? I think this one you already answered, Doctor, about pregnant women also. So we will skip that one, kan, Doctor?
Yeah.
Okay. And the next one is from Dr. Alfred Aldrin. For someone who has recovered from COVID-19 infection, will taking the vaccine have any positive effect on long COVID syndrome?
Okay, so a person had COVID-19 before, and the question is whether taking a COVID-19 vaccine, would it reduce the risk of them having long-term COVID syndrome or alleviate the symptoms of long COVID syndrome? I don't think so. It's a totally different. The vaccine is to prevent you from getting infected. It doesn't do anything to people who have already been infected as to whether it alleviates their symptoms or not. Yeah.
All right. Next one is from Hussein. What is the efficacy of Sinopharm vaccine, doctor?
It still ranges between 50 to 70%. Having said that, they haven't released their data, and they haven't published their data. So they may have released their data, but they haven't published their data. So it's very difficult for us to comment on the efficacy. Most of the vaccines, it's good. Most of the vaccines have an efficacy of more than 50%, which is actually very, very good in reducing the risk of transmission and infection. I can't comment much because they haven't published their data on it. Yeah.
All right. Next one is from Dr. Alagamai. Should we give after the first trimester? I think maybe she meant the COVID-19 vaccine.
COVID-19 vaccine?
Yes.
I think the question is the same. We have to balance the risk and the benefit. We have to discuss with the mother that we don't have any long-term pregnancy data on it. However, the risk of them getting COVID-19, severe COVID-19, if they're pregnant is higher than if they are not pregnant.
All right. Yeah. Next one is from Shuhada from Gleneagles, Medini, Johor. I would like to ask if current vaccine cover us from various variants of COVID-19, especially the UK variant that is reported 64% more contagious.
I think the Pfizer-BioNTech vaccine, and this in Israel, shows that the efficacy against the UK variant is good. It's still good despite the reduction in the production of neutralizing antibodies. Yeah.
All right. Next.
I think I'll go on further to ask, as new variants come about, would the vaccine still be effective? The answer is we don't know. We don't really know until we get the results and we see how effective it is. So a lot of what I have said today and presented to you today may not be true later on, and new information is coming out every single day. How the variants will affect the vaccines, we still do not know. Having said that, it is reasonable, plausible to think that we will have to modify our vaccines after some time, and if the variants mutate and become resistant to it.
Okay. Next one is from Dr. Elizabeth from Clinic Malaysia. Has there been any adverse reaction to the first dose of the vaccine reported in Malaysia so far, doctor?
I think Dr. Elizabeth means whether there has been adverse reactions, because many people do have mild adverse reactions. I'm unable to answer that because we haven't had any release of any information on that. So I'm just as we're just waiting for any news of it, just as you are. Yeah.
All right.
It's not been reported. No?
Okay. A viewer named Brian also asked the same thing, doctor, and also.
So I think when you mean adverse reaction is anaphylaxis, severe anaphylaxis. Well, it is inevitable that there will be people who get anaphylaxis. As I said, the risk of anaphylaxis is 5 in 1 million for the Pfizer-BioNTech vaccine. So, and if you're going to vaccinate 16 or 17 million people, that is 16 times 5, about 80 to 90 people would probably have anaphylaxis. So that's why in all vaccine centers, the question asked is whether you have a history of severe allergies or anaphylaxis before giving the vaccines. And if you do, it doesn't mean that you can't get the vaccine. It just means that if you get the vaccine, then precautions will be taken to treat you if you do develop an anaphylactoid reaction to it. Yeah.
All right. Another one.
I think the other question is, I think I'll just proceed.
Okay,
so
sure.
if you have an allergic reaction to certain drugs, you have allergy, should you still get the vaccine? The answer is yes. You should still get the vaccine, but under precautions, right?
Okay.
Precautions.
So next doctor commented in YouTube, if you can still catch the virus after vaccinated, for someone who has severe allergies to GMOs, what are the chances of cytokine cascade or storm?
Sorry, what's the question again?
I can let you read this one, doctor.
I'm not sure what he means by GMOs. I'm not sure about this question. Let me see. I think what he means is if you have been vaccinated, right? And still got the infection, right? Okay, so this is someone who's been vaccinated, right? Who's been vaccinated and then develops another infection despite being vaccinated, and whether they can develop severe COVID or not, answer is yes. You can still develop severe COVID if you are vaccinated, severe COVID, but the studies have shown the risk of a person getting severe COVID after being vaccinated is much lower compared to someone who has not been vaccinated. So yes, you can get severe COVID if you are vaccinated, very severe COVID, but the risk of that is less compared to if you have not been vaccinated.
Okay, let me check for another question, doctor. What about AstraZeneca vaccine for age 65 years and above, from Hussein? Asking.
I think there's some issue with this, especially in Germany, where there have been increase in adverse effect for those above the age of 65 using the AstraZeneca vaccine. I think this the information of this is still evolving, right? I think more and more data, as more and more data come out, then we'll be able to comment more on this.
All right.
So there are concerns about the AstraZeneca vaccine in Germany, but so far they haven't seen such adverse effects in those other countries, especially in the UK. So this knowledge is still evolving. I have to admit that I don't have enough information on that. Yeah.
All right. Doctor, sorry, back to the question just now, the one that if you can still catch the virus after vaccinated for someone who has severe allergies to GMOs. GMOs stand for genetically modified organism. What are the chances of cytokine cascade or storm? Do you have any comments on that, doctor, or maybe we can go?
No, I think
Okay, we can go. All right.
I mean, like I said, I mean, if you get a severe COVID infection, you can go into a cytokine storm, and if you do go into a cytokine storm, there's treatment available for it. I think the question is whether a person with a history of allergy to this has a higher risk compared to someone who doesn't. That one I do not know.
All right. Next one, if patient have rheumatoid arthritis as it is autoimmune disease, so can he take vaccine or not?
Yes.
Can.
Yes.
All right. And next one, does long-term use of steroid affect efficacy of the vaccine, doctor? Long-term use of steroid.
So far, the vaccination has been encouraged for those who are immune suppressed, especially also if they are taking long-term steroids. Theoretically, if you suppress your immune system so much, the vaccine may not induce the immune response that we want in creating the immunity towards the virus. So it is encouraged, it's still encouraged, but whether the efficacy is the same or not, it still remains to be seen. So we do not have the answer for that yet.
All right.
So as more and more data come back, then we'll be able to see whether those people who are vaccinated but on steroids or immune suppressed, whether they're at a higher risk of getting infected despite being vaccinated.
No.
So we'll have to wait for the data to come out.
All right, noted, Doctor. And to all our viewers, thank you for all the questions. And unfortunately, we have very limited time, so we will get Dr. Timothy to answer your question after this live. And before we end, Dr. Timothy, do you have any last remarks for our viewers today?
Well, I got my vaccination yesterday, and I'm feeling well today, and I'm due for my second vaccination on the 31st of March. So I hope that all of y'all would get vaccinated, and please encourage your parents to get vaccinated as well. Do not fear the vaccine, but fear COVID, and let us try and end this pandemic together. Thank you. Thank you for your kind attention.
All right. Thank you once again, Dr. Timothy. To all our viewers out there, as you can see on the screen, we are showing you our current package promotion, which is the health screening package. We have 4 packages: Basic, Basic Plus, Privilege and Premium. If you are interested or should you need further details, please do let us know. This promotion is valid till 31st of March 2021. Next, for all doctors, please do not forget to scan the QR code at the end of this live by using your MMA Doctor Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link which is specified for doctors only in the description just under this video to confirm your attendance manually. And to all the Gleneagles Hospital Kota Kinabalu staff who are watching this now, please do not forget to click on the link which is specified for nurses only in the description to confirm your attendance. Please make sure you click the correct link for your attendance. And also, we have another online CME session with our resident gastroenterologist and physician, Dr. John Cheng, on 16th of April at 6 p.m. with the topic of fatty liver disease. Let me know if you are interested. We will share the details with you. We have come to the end of our online CME today. Thank you very much for listening to us, and see you next time.